From 12 News, this is Newsmakers.
Lifespan is a dominant force in local healthcare. Rhode Island's largest health system owns hospitals stretching from Providence to Newport, and with over 16,000 workers, it's also the state's biggest employer. Now, Lifespan has new leadership, but familiar challenges, from a fast-changing medical landscape to negotiating a deal with Providence's mayor over payments in lieu of taxes.
Every nonprofit institution in the city of Providence is making a payment except for Lifespan.
Our guest this week on Newsmakers, President and CEO of Lifespan, John Fernandez. Welcome to Newsmakers. I'm Tim White alongside 12 News Politics editor Ted Nesi. Our guest this week, the President and CEO of Lifespan, John Fernandez. John, welcome to the program.
Thank you. Good to be here.
So look, you were an executive at one of the most renowned hospitals in the country, I would argue, Mass General Brigham. Why did you come to Lifespan?
Because I saw a great opportunity to help people in this market. Saw a great leadership, a lot of opportunity, and so decided to do it. And I'd been at Mass Eye for a long time.
So
loved it.
Why don't we dive into some of the challenges that you already have to, face in your new position as president and CEO?
We see them as
at
opportunities,
Lifespan.
by the way.
Okay, I like it.
Very corporate.
Yes. So our viewers understand Lifespan, of course, is a nonprofit, so it does not have to pay property taxes to the city of Providence, like colleges, universities, churches, so on and so forth. Instead, Lifespan has in the past made what's called payment in lieu of taxes, or pilot, but hasn't for more than a year or so, as the last deal with the city expired. Just a few weeks ago, we had on Providence Mayor Brett Smiley on the show, and he was pretty frustrated with your organization. I want to play a quick soundbite with the mayor and then get your reaction to it. Here's Mayor Smiley.
So there's been no substantive progress. I will say that we have a meeting on the books for early October, about 3 weeks from now, to actually start negotiating.
Did you expect it to take that long to get a first meeting?
No, it's been very frustrating for me. They did not make a payment last year. Lifespan has not had a formal agreement with us. They've had a policy. I guess it's fair to say that when they have a good year, they throw us something, and when they don't, they don't. That's deeply offensive to me.
That's Mayor Brett Smiley on the program a couple of weeks ago. Deeply offensive to me. How do you respond to the mayor?
We have a meeting with him in October, and we look forward to working out. We're going to help support the city, but we just have to have that negotiation with his team and move on.
Well, the hospital, Lifespan, has not made a payment, as I said, for over a year. I acknowledge that you inherited that, right? So that wasn't a decision that John Fernandez made. But coming in and looking at it, is that fair?
I don't know what's fair or not. I wasn't here. I think it's better just to work these things out with the city and come out with a plan in the future. It's that simple. Negotiating in the press is not what I'm going to be doing.
Well, in fairness, though, we've watched this a long time, and you just got here. So Lifespan's always been super resistant. It's been, clearly from the board level, including to making a set pilot agreement. But it sounds like you are at least open to that, then, if I'm hearing you right.
Yep, open. Looking forward to talking to the mayor and their team. That meeting set up in October.
Did Mass Eye make one?
Yes, I mean in the Boston area, the pilot's not a new concept in most big cities, so not new to me. So we'll see how we work it out.
Have you personally talked to the mayor about this?
Yeah, we met in April. I got here in February. We met in April to sort of meet and greet, which I did with many business leaders and political leaders, and then we met again this summer, and then the meeting set up for October. And I've talked to him on the phone, seen him at meetings, sat next to him at the chamber event. So getting to know the mayor, getting to know a lot of people.
Well, let me just ask you a different way. You seem a little reluctant to talk about it, but it is an important issue, John.
Because I am.
Right, I get it. But do you understand the mayor's frustration with the situation?
I understand it. He's entitled to his frustrations and opinions, but that's why we're meeting in October to work things out.
And how long do you think the process will take?
I have no idea. I haven't done this in this town. The schools took a while. We'll work as fast as we can.
Okay. All right. Let's pivot here. COVID infections are going up. I know you're not a doctor, but you run the hospital in Rhode Island Hospital.
Right.
Take us inside right now. What are you seeing in, I guess, the emergency department? Are beds filling up? Are people dying right now? What's going on in your hospital?
So I'd say two things. One is we have seen an uptick, just like you read about in the newspaper. We're worried, but we're watching it. We encourage people to, if they have underlying medical conditions, to wear a mask. But I think we have to be measured. Point number two is we have to be measured in how we react to this as a state, as a region, because there are lots of infectious diseases. But it's a serious matter, especially for people who have other medical conditions. So we're seeing the uptick, and dealing with it is not crushing us. Staffing's our biggest problem, not COVID.
We'll talk about that because that was an issue out of the pandemic, and when traveling nurses were coming in. Are you still heavily relying on that?
Still relying on it. 100 nurses. It varies week by week, hospital by hospital, but we still we're trying to retain more people, recruit more people. So it's still probably in healthcare in general. If you go nationally or locally, it's our if I could solve one thing, I'd solve how do we have more nurses and techs and medical assistants and so forth. Our people are the most important part. So, and we've seen hard to recruit places like in the operating room or psychiatry. Nurses in those areas have been. Then we don't have nurses. We can't open a bed.
So
and then
OR nurses are particularly difficult to hire, or
yes.
Okay.
Yes, and psychiatry recently. To work on those floors, but what you see is when we can't open the beds, then the ERs back up and people get frustrated with long waits. It's often not the ER, it's trying to get the patient either to someplace else or up into a bed.
Yeah, my family experienced that, not at Lifespan, at a different hospital.
But those are systematic things that we have to just sort of every day work on, and the team's working on it. We made a lot of progress in the last several months, but it's not fixed.
Just shortly before your predecessor, Tim Babineau, departed, I spoke with him, and he at the time estimated that Lifespan had 2,400 vacant jobs, and he said a big priority was going to be filling those. Again, understanding that this was your predecessor before you were here, do you have any sense of where that number stands now?
I know it's less. I have no idea what the number is.
Okay.
But there's still, if you need a job, send us your resume. We'll gladly take you at Lifespan.
Good idea. Using the platform here to
Might as well.
Opportunity. What is the biggest headwind with retaining jobs right now? Is it just as simple as pay?
No, it's competition. It's just a raw number. I mean, let's be honest.
Isn't competition another way to say pay?
It can be. They think the grass is a little greener someplace else. They go one place, come back. We just have raw numbers that people. Let me give you an idea.
Sure.
So, if you're a nurse and you're working 5 days a week, and let's say there's 100 of them, and 100 say, you know what, I'm going to work part-time. They're still there, which is great, but that's if they go 2 days, if they go to 3 days a week, that's a 40% decrease in the number of nurses that we have to go then find them. Mm-hmm. And it's just tough. It's competitive regionally, nationally. It's just, and we've known the nursing crisis was coming for 20 years. Around the country, we knew it in Boston. The pandemic accelerated, didn't create it. So we're working hard with Providence College is opening a nursing school. The other nursing schools in town are doing a lot to how to get accelerated programs. Working really, really closely with them and our other hospital colleagues because we just need more humans going into nursing. I did my part in that. My daughter went into nursing school a couple of years ago. Now she's working in Vermont, unfortunately. I tried to get a package deal.
You can't recruit your own daughter, oh my goodness.
I better get working on it.
Yeah, exactly.
But I do think we have to create an environment. We're doing this in primary care. How do we create an environment that people want to come work as opposed to going, oh God, it's going to be an overcrowded ER or whatever it might be.
Well, to that, something I think, Tim, too, we have been hearing a lot in the last couple of weeks from rank and file hospital folks is about safety because of that incident at the hospital with the nurse who I believe was attacked by a patient. Yeah. First, just a basic question, without filing patient confidentiality, is there anything you can say about how that nurse is doing?
I really can't talk about the patient's condition.
Well, then speaking more broadly, the concerns I heard were, first of all, I think a lot of people are attributing that to staffing, and I'll let you speak to if you agree with that. And then I'm sure I would assume you were horrified too to hear about that. So what's hospital leadership doing after seeing that occurred?
Yeah. So first, it is horrible. We can't have. It's unfortunately not the only attack on healthcare workers. It's happened at other hospitals. It's happened at our hospital before then and since then. So it's just horrible that our healthcare workers that's happening. This was obviously an extreme event. It's so sad that we have one of our colleagues in the hospital. But what we are doing is we've relooked at our security, how we train people, more training. In this particular case, I would not chalk it up to staffing, but staffing does matter. Or if you have closed beds and full ERs, people waiting 8 hours, we got to fix those problems. Will help, but there's no one single bullet on solving this problem. But it's just horrible.
So I imagine the hospital is investigating, looking into what happened. Maybe already has. Do you have a sense as to what went wrong? In other words, should the patient have even been at Rhode Island Hospital at that time? Was there a breakdown in any systems or protocols?
I won't talk about this particular case, but I would say there are a lot of patients that stay in our hospital, a long time. They could be in another facility or at home, and we have a very hard time getting patients out. We've had several incidents. When I got there was a patient that had been there 1,000 days. That's like 3 years.
Yeah, it's a long time.
Yeah.
But I thought, okay, that's just one outlier. But we have a list we keep of the long stay patients, and they can't find a nursing home to go to. They have no home solution. They're not medically needed to be there. And then that takes up a bed that's blocking up the ER, and you can just see the system problem with that.
I've heard the same thing from doctors in recent months. Is it because we have lost nursing homes? Is it that they have the same staffing issues there? Is there something else going on?
I think all the staffing issues, less beds. The state is working on the Eleanor Slater house. I don't know all the details there, but there have been less resources than there were in the past. So we have to fix some of those, I would call them out-of-hospital solutions, to then make it easier for us to care for the patients that need the medical care, not just the housing.
So there was a point in recent history, a sort of tension point between Lifespan and Care New England, the closest, I suppose, rival. Lifespan quasi-threatened to open a delivery unit. So Care New England operates women and infants, and that is their bread and butter. Is Lifespan still considering that now?
No.
I'm
not working on mergers. I said it the other day at the chamber.
Well, I wasn't asking about a merger. I was asking if Lifespan was considering opening a delivery
unit. Neither merging nor
to
fighting at the moment?
No, Mike and I have decided it's better.
Mike Wagner, the new CEO at Care New England.
That better working together. We look at our competition, I think, differently than in the past. Our competition is not C&E or Lifespan or the other hospitals in the state. It's Amazon. It's the other parts of the health system.
Explain that, because people might hear you say that and go, what do you mean that Amazon's competing with a place that,
I'd rather have my knee replaced at the Miriam than at the Fall River Distribution Center.
They're not doing the knee replacements yet, but if they can figure out how to train a robot to do it, they might.
Oh, boy.
But if you think of some of the profitable parts of a health system, the Amazons, and they're not alone, they're Walgreens, you could sort of pick the list and you can read the newspaper, are working on how do we get the primary care or the easy stuff that then they take care of that, and then they get redirected to other places or pharmacy or stuff like that.
Leaving you with the more expensive stuff.
More expensive, and the people have less well-paid insurance. And so people go, wow, it's really efficient if we take all the people who are young, healthy, and have insurance, and then if you're not any of those things, you go to one of the hospitals. It's not, it's the American system, not great, but that's the way it works. And so we have to, that's who we're competing with for the minds of those patients. But it's fine. I sort of enjoy the competition. It makes us better. We should provide better access to primary care. We're working on that. Same with our specialists. You should be able to use your cell phone to make. Look, I don't have much hair, but I can schedule my hair appointments online. You ought to be able to schedule a visit online.
Why don't we dive more into that in the second half of the program? We're going to take a break. John Fernandez, he's the president and CEO of Lifespan. Stay with us. You're watching Newsmakers. Welcome back to Newsmakers on Tim White alongside 12 News Politics editor Ted Nesi. Our guest this week is President and CEO of Lifespan, John Fernandez. Ted?
So, John, we reported last week that your predecessor, Tim Babineau, made $3.2 million in 2021, which was the year before his unexpected, to me at least, departure as CEO. One of the people we spoke to as we were reporting out that story was Lynn Blaze, who's the president of UNAP, the nurses union. I want to take a listen to a little of what she had to say. Oh, sorry. Your reaction when you hear Babineau made $3.1 million?
That's obscene. Absolutely obscene. We make the same argument that our trauma center here in Rhode Island should be being paid the same numbers that the nurses that are working in a trauma center in Boston. And we're told, if you want that money, work in Boston. So if a CEO wants that money, work in Boston.
This is a perennial complaint we hear around here about executive compensation at Lifespan. How do you respond to the complaints from people like Lynn?
I don't. Actually, comes up every year. Executive comp is always a hot button item. It's frankly a no-win conversation. So I understand how she feels, but boards make those, comp committees make those decisions. It's a competitive market, so I really don't have, and that for me, that's all in the past.
I guess the thing that Lynn said there that I thought was just an interesting point was she says that the nurses are told, you're in Rhode Island, you got to get paid Rhode Island prices. But then when we do the executive compensation stuff, we hear, hey, we're competing with Boston for executive talent. I mean, why doesn't it apply to both jobs? Or do you think it does?
I think it applies to both. The competition for nurses, just like the competition for management, doctors. They might be a little lower than downtown Boston. People like to always take MGH or the Brigham, but we look at salaries from a competitive point of view all the time. So I don't think it's actually from a process point of view any different, but it's always an issue for my many years in this business. It comes up every August or September, depending on when the reports come out.
When the Form 99 is going.
Yeah.
I am curious, you mentioned your time in Boston. So you, as we've been talking about, you were at Mass General Brigham. So now you're getting a firsthand view of the hospital situation in Rhode Island, in Providence, your own and the others. Other than size, what are the biggest differences you're seeing down here? Is there anything that surprised you, knowing the Boston hospital scene so well and seeing down here?
Well, first I'd say no surprises. Did enough homework, and it's sort of, we're all in more or less the same market, so it's not like a news flash what's going on in this state. I'd say the bottom line problem is we got to create more jobs in this region for people that have good, well-paying jobs that have insurance. And that's in light and self-interest because right now 30% of our patients are on Medicaid. We need to get more jobs so people have those and then can pay for health care.
But and that number, I think, kind of undersells, right? I think it's the mix that you're talking about is 69% of revenues are from the government. So Medicaid and Medicare, right? And of course, those are different streams, and the rest are private insurance. So to Ted's question, you say there were no surprises, but how does that compare, let's say, to what Mass General Brigham sees?
Yeah, so I don't have the exact numbers, but it's probably about half.
So it's more of a 50-50 mix.
50-50, 60-40, and every one of those percentages makes a difference. There's two things when you look at healthcare economics. One is the payer mix that you're talking about, and the other one is sort of service mix, surgery, medicine, OB, psych. The mix of patients also determines the revenue stream. So I would say there's health systems that have a higher surgical volume, which you tend to be paid more for, versus a higher medical volume. But the biggest thing is that, do you have insurance and which kind?
And I mean, just so let me state, master the obvious here. Private insurance pays the hospitals better than the government insurance,
it's been
right?
Cross-subsidization for the last my whole career.
Yeah.
So you make more on the commercial side and you make less on Medicaid, and Medicare's in between the two.
Now, Medicaid, and just because I know people get them confused, Medicare is for older Americans, Medicaid is the state-federal split for lower-income Americans. Medicaid payment rates in the state of Rhode Island have been a huge issue for quite a few years now. A lot of complaints about how low they are compared regionally. But I'll be honest, the other day I was reporting on the state's budget picture, and it feels like the flush times are winding down, and so it's going to be even harder to convince state leaders to make any big push on increasing Medicaid payment rates. How important is that to you, getting better Medicaid payment rates out of the state to stabilize the finances of Lifespan as well as the other hospital systems?
Yeah, I think you may know we got the state got increased Medicaid funding because we changed the way the licensing fee works, which is a mechanism with the federal government. If we put in more, we can get more from the federal government. So that's helped all the hospitals and was passed in this year's state budget. So that was a huge help. We got a long way to go. We'll probably lose 30% on our Medicaid patients. So anything we can do to, even now, sort of ratchet up that slowly each year if we can to keep. And inflation is going up. I forget what the percentage is the last month, but we see it in our operating budgets, and if we don't keep up on the revenue side, it just gets worse.
Now, we're talking about bad news. I saw some good news, too, as I prepped for the show, which is that in the first 9 months of your fiscal year, you guys go through September 30th, actually right about now is the end of your fiscal year, but through June 30th, so 9 months of your budget year, you had a slight operating profit. This time last year, there was a big operating loss at that point. What's driven that stabilization, at least in the bottom line for you?
So FY22, so we're in FY23, we're October 1 to September 30th. We lost almost $80 million last year, so that was a pretty bad year by any measure. And what's happened this year, we've had a little pickup in volume, a little less of paying for travelers and higher expense, not a lot. And there are a lot of, we got some FEMA money. There's a whole bunch of, I would call them step-by-step things that happened this year, and we hope next year will be better. And to be blunt, we need to be making a 3 to 5% margin so that we can invest in the programs and the facilities. The facilities, you don't need a engineering degree to walk around them and go, we need some help here. We have about $1.2 billion of deferred maintenance. So we are working hard to get to that 3% margin and hopefully more. And the margin, I think the most important people listen to, they need margin. What does it go to? It goes to more research. It goes to fixing our facilities. It goes to new programs that care for people. It doesn't go to stockholders. It doesn't go to some mystical place. So making a margin is not a bad thing because we can do more good for the patients that need it in the state.
We have a few minutes left. I want to touch on this briefly. Hospitals, I don't need to tell you, are one of the top targets for hackers, and Lifespan is not immune, right? I mean, you've seen Rhode Island Hospital. Our colleague Kate Wilkinson has done some reporting on this. Rhode Island Hospital was impacted by it. What is Lifespan doing to deter cyber attacks?
We have a very comprehensive, ongoing, every month, week. We have people that worry about this all the time. We get attacks all the time. You can talk to any hospital executive. You almost don't want to know, but you're getting attacked on a daily basis because it's basically a public institution with lots of money flowing through it. And if you just think of the patient volume, thousands of patients every day coming through. A lot of people, a lot of revenue cycle.
Social security numbers and so on and so forth.
So it's if you're trying to hack in, it's one of the places. And there've been some highly publicized ones like at Children's Hospital in Boston. And so it is just an ongoing expense, an ongoing effort, vigilance, testing staff so you don't click on somebody sending you hacking emails and stuff like that. But it's just a brutal effort every day.
So you've been involved in, and I have to tell you, I've covered Lifespan almost 15 years. I've seen, I feel like, umpteen strategic reviews and new plans, but you're doing one as the new guy in town. My understanding is you had meetings throughout the summer, strategy sessions with Lifespan leaders. Once again, anything that surprised you or anything that really stood out to you as you sort of took the pulse of the health system over the last couple of months?
I think what stood out to me is that we engaged a lot of people, even over the summer, and seemed to be very well received, that we were engaging staff, whether they're or nurse managers or doctors from different groups. We've been pretty open about it. We look at strategy as an ongoing exercise, but I think that was the most rewarding part, was to get people engaged in what do we want to be when we continue to grow up.
I saw one interesting idea, and I'm not saying you were endorsing this, but some people suggested a renaming, maybe even calling it like Brown something or other like that. Would you consider a different name than Lifespan?
Sure.
Sound like you're open to everything, John. On the show.
Remember,
not
challenges
everything.
are opportunities.
Yes,
Is that what you-
exactly. Wow.
is that what
Okay.
you said?
Yeah, I know. What about free healthcare for journalists? Are you open to that?
Yeah, if they make a big donation.
Oh boy.
Exactly.
So we have 1 minute left, and Ted actually flagged this for me that Lifespan has an open house for your medical research group coming up. Can you talk about that? What is it, and who's invited?
An open house? I have no idea.
Rhode Island.
You're speaking at it.
It's a 2023 Research Day.
Oh, yes, that's next week.
You have a
Yeah.
lot going on. So.
Yeah. Thank you for reminding me on the schedule. We have a great guy, Barat, who's been organizing our researchers. We've been working with Care New England, Brown, and the School of Public Health, both medical school and School of Public Health, to how do we make it easier to do research together. And so we have a session to talk about how we're making progress to make it easier for our researchers and how do we recruit and what are the next steps there. So I'm excited about, we call it Birch. I won't even get into why it's Birch. If you want to learn about birch trees, we can do that afterwards.
Yeah.
But it's really, I think, exciting for our research community to go, how are we working together, as opposed to, there's no need to compete on who's doing the administratium for research. So the research day is to talk about where we're going in the future.
John Fernandez, thanks for joining us. We appreciate it.
Thank
We'll
you.
see you next week on Newsmakers.